Good day, Dr. Bandeleria. My name is John Alan, a Doctor of Communication student and currently based in Sydney, Australia. In my first faculty marked assignment, I introduced the World Health Organization's Advocacy, Communication and Social Mobilization or ACSM program for tuberculosis control. In my second assignment, I developed the Integrated ACSM Evaluation Framework or IAEF as a communication-based framework for evaluating ACSM programs. Today, in my third and final assignment, I will apply that framework to evaluate the WHO ACSM program and identify both its strengths and opportunities for improvement. Rather than asking whether the program is simply good or bad, the framework allows us to examine how effectively it transforms a social issue into sustainable social change through advocacy, communication, and social mobilization. Let's begin. Before presenting the evaluation, let me briefly revisit the Integrated ACSM Evaluation Framework. The framework places the ACSM program at the center because it represents the communication intervention being evaluated. Surrounding it are the three core components of ACSM: advocacy, communication, and social mobilization, which work together to address a social issue. The outer ring consists of 5 evaluation dimensions: social issue definition, advocacy impact, behavior change, stakeholder collaboration, and monitoring, evaluation, and sustainability. Together, these dimensions provide a systematic approach for evaluating communication programs and their contribution to social change. The first dimension examines whether the program clearly defines the social issue it seeks to address. In this area, the WHO ACSM program performs exceptionally well. Rather than describing tuberculosis solely as a medical disease, the handbook recognizes that TB is also influenced by communication barriers such as stigma, misinformation, delayed diagnosis, poor treatment adherence, and limited political commitment. This broader perspective reflects the concept of social change discussed in Module 1, where complex social problems require coordinated communication interventions rather than medical solutions alone. For this reason, I rated this dimension 5 out of 5 stars. However, I recommend that future editions continuously update communication priorities to reflect emerging issues including digital misinformation and changing public communication environments. The second dimension evaluates advocacy. The WHO ACSM program strongly emphasizes political commitment, policy development, funding support, and institutional leadership. These are essential elements of successful advocacy because sustainable public health programs depend on supportive policies and long-term investment. However, the communication environment has changed considerably since the handbook was published in 2007. Today, advocacy increasingly occurs through digital platforms, online campaigns, social media, and collaborations with trusted influencers. Therefore, while the advocacy component remains highly effective, I recommend expanding digital advocacy strategies to strengthen engagement with contemporary audiences. This recommendation is supported by advocacy principles, which emphasize adapting communication strategies to evolving political and social contexts. The third dimension evaluates whether communication activities encourage meaningful behavior change. The WHO ACSM program provides extensive guidance on increasing awareness, reducing stigma, encouraging early diagnosis, and promoting treatment adherence. These objectives align closely with behavior change communication. Nevertheless, communication practices continue to evolve. Interactive technologies, mobile health applications, personalized messaging, and artificial intelligence now offer new opportunities for improving communication effectiveness. Accordingly, I recommend integrating more digital behavior change strategies while maintaining evidence-based communication principles. This recommendation is grounded in behavior change communication theory, which emphasizes that communication should influence knowledge, attitudes, and behaviors. The fourth dimension examines stakeholder collaboration. This is one of the strongest aspects of the WHO ACSM program. The handbook promotes collaboration among governments, healthcare providers, community organizations, non-government organizations, donors, media, volunteers, and affected communities. Such partnerships strengthen trust, improve program reach, and encourage shared ownership of health initiatives. For this reason, I assigned the highest rating to this dimension. To further strengthen collaboration, I recommend expanding partnerships with universities, technology companies, youth organizations, and digital community networks. This recommendation reflects social mobilization theory, which recognizes collective participation as essential for sustainable social change. The final dimension evaluates monitoring, evaluation, and sustainability. The WHO ACSM program acknowledges the importance of monitoring program performance and documenting outcomes. However, modern communication programs increasingly rely on continuous feedback from communities and stakeholders. Evaluation should therefore become an ongoing learning process rather than a final reporting activities. I recommend incorporating real-time feedback systems, participatory evaluation methods, and digital monitoring tools to strengthen continuous improvement. This recommendation is supported by systems thinking, where feedback enables communication programs to adapt to changing environments and improve over time. Overall, the WHO ACSM program demonstrates a comprehensive and well-designed communication framework. Its greatest strengths lie in defining the social issue, integrating advocacy with community participation, and fostering stakeholder collaboration. The primary opportunities for improvement relate not to the framework itself, but to adapting it to today's digital communication environment through stronger online advocacy, modern behavior change strategies, and continuous participatory evaluation. To conclude, applying the Integrated ACSM Evaluation Framework demonstrates that the World Health Organization's ACSM program for tuberculosis control remains a strong model for communication-driven social change. Its integration of advocacy, communication, and social mobilization continues to provide valuable guidance for addressing complex public health challenges. At the same time, communication is constantly evolving. Programs must adapt to new technologies, changing stakeholder expectations, and emerging communication channels. By strengthening digital advocacy, expanding stakeholder engagement, modernizing behavior change communication, and institutionalizing continuous feedback, the WHO ACSM program can become even more responsive and sustainable. Ultimately, this evaluation reinforces one important lesson from this course. Effective communication is not measured simply by the messages we deliver, but by the lasting social change those messages inspire.